So thanks for your patience. I wanted to welcome you all to our fall Health Insurance Marketplace Advisory Committee meeting. This is Craig Anderson. I am the chairman of the HIMAC, and I wanted to mention that Dawn sent out a packet earlier this week. It should have all the information that we'll be going through, as well as our agenda this morning, and then those items that are marked with an asterisk relate to our work plan. But I wanted to first introduce a new member to the committee. He is our OHA ex officio member, Ali Hassoun. Do you mind introducing yourself and saying a few words?
Yeah, of course, Craig. Thank you very much. Glad to be here with everyone. My name's Ali Hassoun. I use he, him, his pronouns. The current interim director of the Health Policy and Analytics Division within the Health Authority, and the permanent director of the Public Employees Benefit Board and Oregon Educators Benefit Board. And I've been in that position for about 5 years now, and in the interim HPA director position for a little over a year. As y'all might know, they're currently recruiting for a permanent OHA director, and I think are getting closer to finding that hire, and then I think they'll move on and fill the HPA director position. But I have some background in the marketplace. I actually was hired to bring up the financial management part of the system back when the exchange was, I think we had 5 people working in a house down in downtown Salem, and I took the opportunity to get involved in that project and worked closely with Katie, and for a little over a year, until about the time that the exchange, Rocky decided to move up to Portland, and I had young children at the time, and it was about the hardest decision of my career to go back to PEB and OEB, but I was having so much fun and learning so much, and it was such a great project to be part of, and I'm really always had a real soft spot in my heart for this work and this this team that Chickies assembled, and so it's just really a pleasure to be part of this. Thank you.
Thank you. We didn't think you had enough to do, Ali, so we do this committee.
Appreciate that, Craig.
All right, so next we're going to go through the roll call, if that works.
All right, so if you are joining by phone and video, please indicate so. And if you're here in the room, please also let us know. Roll call for Health Insurance Marketplace Advisory Committee for the 10/12/2023 meeting. Craig Anderson.
Here in the room.
Gladys Batwell.
I'm here on Zoom.
Thank you, Gladys. Ron Gallinet.
Here on video.
Thank you. Paul Harmon.
Here on video.
Thank you very much. Ali Hassoun.
You're on video.
Lindsay Hopper.
Present by Teams video.
Ines Kemper.
Present by Teams video.
Shannon Lee. Here in the room. Joni Moore.
Here virtually.
Danielle Nichols. Holly Sorensen.
Good morning, I'm here on video.
Andrew Stolfi.
Amy Griffith on behalf of Andrew Stolfi here in the room.
Om Sakinai. Ms. Shobha Temperley.
I'm here via video.
Thank you. Did I miss anybody on the committee for the roll call? Fantastic. We definitely have quorum.
Okay, that's good. Dawn, is it possible to pull up the, still working on that?
Just now getting back in there. My computer decided it wanted to do the updates.
Oh, well, it's always fun too.
Sorry about that.
Well, while you're pulling that up, I think I'll just go through the meeting guidelines. And just as a reminder to everybody, the Marketplace and the HIMAC is committed to safe and inclusive meetings for all attendees. Please do not hesitate to offer your perspective and ask questions. If you notice any unacceptable behavior, don't hesitate to bring it to Chickie's attention. Also, be on camera as much as you're comfortable with, and raise your hand either in person or virtually if you want to ask any questions. If you're virtual, you also have an option to put questions in the chat. And lastly, there is a captions feature. And I think we can continue with our business here as Dawn gets this brought up. And the next order of business is the approval of the previous meeting minutes. And those are from July, our July meeting. Dawn sent those out to everybody to give you all an opportunity to provide some input. And is there any discussion about the meeting minutes? Okay, hearing none, do I have a motion for the approval of the July meeting minutes?
Ron Gallinat, I move to approve the meeting minutes.
Thank you, Ron. Do I have a second?
This is Lindsay. I'll
Ines
second.
Kemper, second.
Okay, I think Lindsay, you just beat out Ines. And then all in favor, either say that or put that in the chat, please. Aye.
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 Okay, thank you. All right, now we're going to keep moving along to our next order of business, which is to introduce to everybody, although she needs no introduction, Stephanie Keenan from McGuire Woods, and she'll be giving us a federal health policy update.
Good morning, all of you. It is a little afternoon here, and I apologize if you hear background noise. My office is on Black Lives Matter Plaza, which frequently has demonstrations, and we apparently have one going on right now. So it's been a little noisy as I've listened to you all. Hopefully it doesn't interfere with you being able to hear me. Today I'm going to talk about three things. One is where we are in funding the government and what it means if we have a shutdown.
Salil is
and
message after the tone.
Oops.
When you have finished, please hang up or press the pound key for more options.
Is everybody hearing what I'm hearing? Yeah, I'm going to go ahead.
Yeah.
The second thing I'm going to go through is just a brief update on where we are with pharmacy benefit management reform legislation. And the third thing is just a brief mention about where we are on implementation of the No Surprise Act, which had to do with no surprise bills. Let me first start with where we are in Congress and why we're where we are. We are currently operating the government under a continuing resolution, which goes until November 17th. That's about 36 days away. As you know, the House has no speaker. Although Steve Scalise won 113 votes in the Republican caucus last night, he needs 217 votes, and he doesn't have 217 votes. There's about 222 Republicans. They have to decide whether to put his nomination up on the floor and have a messy little fight like they did last time with McCarthy, or give him time to try to win over people who have said that they won't vote for him. So that either way, we will not have a speaker for a while. And what does that mean? Well, to give you the most graphic example of what that means in terms of appropriations and funding the government, the House and Senate majority and minority staff of appropriations, they're known as the Four Corners, can't even talk to each other right now because the House has no direction. Both the House and Senate are out this week. Both are expected to be back in next week. If they're still looking for votes and trying to figure out what to do in the House, we may not have the House back, but they're supposed to be back. Appropriations covers discretionary spending, which is honestly just about 17 to 18% of the federal budget. It does not include Medicare, Medicaid, or Social Security. There are 12 appropriation bills that have to be passed, either individually or packaged up. And we don't have any bills that have been passed by both bodies, meaning that they're in law. So that's why we're operating under the continuing resolution. Most people in DC are betting that on November 17th, when the current CR runs out, we will have a shutdown. And that it probably will run through at least Thanksgiving. And if that happens, the Department of Health and Human Services, when we thought we were going to shut down earlier this month, had already put out a contingency plan. But just to give you an idea of what the contingency plan covers, HHS would retain 58% of its staff, while 42% of the staff would be furloughed as of day 2 of the just funding disruption, as they call it. CMS would retain slightly less than half of its staff, and Medicaid is funded through the first quarter of 2024. Medicare continues because that's not part of appropriations, and the CMS Innovation Center would continue because they're funded in a different way. CMS would maintain staff necessary to make payments to eligible states for the Children's Health Insurance Program, the CHIP program. And CMS would continue federal exchange efforts such as eligibility verification, and they would be using carryover federal exchange user fees for that function. CMS has also told the states that they would continue the advanced premium tax credit calculations. But I will tell you that calculation is actually done by the IRS, and the IRS still hasn't answered some of the staff on the Hill about whether or not they would continue doing it or would continue doing it to a point. In the last government shutdown, which was about 35 days, they opted to do it for about the first 20 days, and then after that, they didn't have any funding to continue to do it. So it would continue, but I can't guarantee that it would continue for the length of if we have a very long shutdown. CMS has been assuring Medicaid advocates that oversight of the unwinding process would continue. But I want to caution that even though they will still have staff there and still be trying to function, that staff will be spread thin, and everything, whether it's in Medicaid, whether it's in Medicare, or whether it's having to do with exchanges, will be much slower because they simply won't have all of their staff there. And just, to give you kind of a lay of the land about where we are, other than just being speakerless, therefore we can't go anywhere. House Republicans in conversations are bringing up the issue of Medicaid work requirements and putting that in an appropriations bill. There's been some discussion about some other things that Democrats would not like. There's been a discussion of creating a commission to look at the budget. And some have pitched that as a compromise position if we can't get some spending cuts that the Republicans want. And I'll just say that there's no reason for Democrats in the Senate to take that. And even if it did happen, every commission that's been created to look at the budget has been basically ignored. The last one was in 2010. It was the Erskine-Bowles Commission that was done under Clinton. A lot of very good people did a lot of hard work, and it got put on a nice bookshelf. So there's a lot of ideas milling about, hard to figure out where they will all fall. The one thing that's been a little bit disturbing is that you may remember we had an agreement on the debt ceiling, and in that agreement, they agreed what they would do in appropriations, what the top line appropriation numbers would be in every function of the budget. The House started to do appropriations bills that were below that, and the Senate was doing some appropriations bills and throwing in supplemental funding. Some of the Republican caucus is now saying that it doesn't matter what was in that deal because that deal was made with McCarthy. McCarthy's not the leader anymore, so it doesn't matter. So we'll see what happens once they do get a speaker and figure things out. Scalise, just a few words about Scalise and Jordan. Scalise is one of the reasons he's having a hard time there are two reasons he's having a hard time other than the fact that he's kind of identified with McCarthy. One is that he is ill. He does have a blood cancer that he's working through. And the second is that he apparently spoke several years ago at a function in which David Duke was in attendance. And that has got some members on the Republican side going, that's really not a good spokesman for us. If you look at Jim Jordan and Scalise's voting record, they don't differ very much, but their styles are very different. Jim Jordan is very much a bomb thrower and likes to really stir things up and make people mad. Scalise is a little bit more polished in that he doesn't throw bombs, but their voting records are very similar. So it really is a question of styles for them. We don't know how long we will be in this weird position of not knowing what's happening, but every day that they don't have action going and discussions going on appropriations and funding the government makes it very hard to do it at the end. That is why most of us are thinking that there's going to be a shutdown on the 17th when the CR runs out. So moving on to something that's slightly more interesting. Pharmacy benefit management legislation. PBM reform has been a hot topic for both the House and Senate. There have been multiple bills in both the House and Senate. The House packaged up several of their bills, put them together and said, we're going to bring this to the floor. This was before McCarthy was booted out of office. They were to bring it to the floor the Monday before there was the vote on McCarthy, and it got pulled at the last minute, and no one really knew why. It's now come to light that many Republicans were getting cold feet about that legislation. They were hearing stories about what might happen under that legislation that were more about the PBM industry than drug prices, and they got confused. So they just decided to pull it. And right now, it doesn't look like they're ready to bring it back up when they do get working, because the appropriations and Ukraine and Israel will take precedence over all of that. But that may be one of those things they try to revive and bring back in December. Meanwhile, in the Senate, multiple bills have been passed out of multiple committees, and the Finance Committee just reworked a proposal as well. So they are in the process of looking at all of those bills and trying to package them up to get them to the floor. Senator Schumer, the leader of the Senate, had said that he wanted a package brought to the floor. This was before the August recess, and they just weren't ready to figure out how to put all those pieces together. Then he said in September he wanted to do it. Well, we're here in October and we haven't done it. But it is something that is very much on the minds of the members who want to do something. So I expect PBM legislation will move, but probably not till December at the earliest. The last thing I want to bring up is the no surprise billing. You may remember Congress passed legislation called the No Surprises Act. Its implementation has been bumpy, and that's being diplomatic. The first big bump was that when CMS issued regulations on it, the House Ways and Means Committee felt that their part of the bill had been dropped out of the regulations, and they were very angry about it and had and raked CMS over the coals several times about it. But things have gotten kind of worse. There have been there were 4 court cases filed, one kind of by the hospitals, they sort of dropped out. But there were 3 court cases that have been filed by the Texas Medical Association. All 3 have been found at least on the first level for the Texas Medical Association. CMS has put out a new FAQ for people to go and figure out what they're supposed to be doing, and it's made all the providers very angry. House Ways and Means Committee had a hearing at the end of September on the No Surprises Act, largely geared towards telling the story about small providers having difficulties in using the process to mediate bills. And I've been told that the new FAQs that CMS put out have just infuriated the provider community, saying that it makes it even more difficult for them to use the system. So what's the point? I think some people would remind them that the legislation was passed to protect consumers, but it is true that all practices, large, big, and medium, should be able to participate and figure it out in an equitable way. But it appears that right now there are a lot of providers who feel that that process is not going to work. Same time, CMS had stopped looking at, had closed their portal where you're supposed to put everything in. They just reopened it on Friday. And there's a backlog already of claims going in. It's uncertain how, what CMS has said is that, you know, if you file your claims and you were operating under this set of rules, then we'll negotiate under this set of rules. And then there's a cutoff, and it's just made it even more confusing. So expect more action on the No Surprises Act in the future as well. With that, I'll stop and take questions if you have any questions.
Great, thank you, Stephanie. Are there any questions from people in the committee? You see anything in the chat?
Hi, I do have a question. Sorry, Gladys, I'm an insurance broker, so I'm working open enrollment around the corner. So one of the things you had stated, Stephanie, was that on those that are, if there is that shutdown, if it happens, and the IRS is the one that is doing the tax credits and all the other things. So if somebody has a mismatch, they have to provide proof of citizenship. That's something that does happen. Even though I plug in all the information, sometimes they still want to see the green card or passport, whatever. So they usually have 3 months to get that cleared up. And I usually tell my people, do it now so that we have a month, and then after a month we'll check on it again, and that way we have time to submit something else. Income is one that if they didn't like this, let's try that. So how is this whole situation, if it does happen, how is it going to affect that? How is it going to affect, we have open enrollment technically until January 15th. So if, like you said, 20 days later, they said, oh, we don't have the budget to do this. So then what happens?
Well, based on what happened last time, it was on day 20 that they said they couldn't do it anymore. On day 24, you had members of Congress beating up on them to figure out how to figure out what they needed to do. And then the Congress came together and they passed a way to keep the government funding. So it was sort of became a mute question, so that there was only this small time frame where things didn't happen. And everybody was able to make it all up. I've talked to a number of advocates who believe that based on what they've been told, the IRS is aware that their role in making sure some of this happens is pretty important. And for if there was a long shutdown and there's a glitch, like they decide they don't have funding, that all hell's going to break loose. So that they may be trying to find ways to keep it going. CMS has been very assertive in saying, oh, it will happen. It'll be taken care of. So I think we need to go by what CMS says and hope that the IRS doesn't at the last minute say, we can't do it. I know that's not a very good answer, but that's pretty much the way people are operating under. If CMS must be forcing the IRS, and there must be some circular conversations going on there. The other thing I'll say is that things should go forward. They will just be very slow. And hopefully it would not be a long shutdown. But one of the reasons for the time frame of being November 17th, 18th to through Thanksgiving is Congress is supposed to be gone for Thanksgiving. The CR ends on the midnight at the 17th, and it would give some folks time to sort of figure out some things that they can't figure out with all the noise of, we have a deadline. It also, and this is the part that's a little bit painful to hear, there are a number of House members and Senate members, for that matter, who have not been through a government shutdown, and they don't know what it feels like. Now, that doesn't escape any of the pain that would be caused, but there are some members who said for the members who have not experienced it, maybe they should experience one and have to go home and talk to constituents who are feeling real pain. I know that's not a happy answer either, but that's why we think it would be through Thanksgiving, and then probably they'd get their act together and get something done early December.
Thanks for the question, Gladys. Anything else for Stephanie? All right. Well, thank you for the update. We always appreciate it. We'll see you next time.
Yes, you will. Take care.
Okay. All right. Next on our agenda, we are going to have a basic health plan update. So Tim Sweeney and Katie Button are joining us.
Good morning, everybody. Happy to be back and joined by Katie this time, who's actually going to do the bulk of this slide deck. But I did want to start with a few updates related to the basic health program and the progress that OHA is making on that front. As many of you may be aware, back in September, the Oregon Health Policy Board unanimously approved the draft blueprint for submission to CMS, and this blueprint was formally submitted to CMS 2 days later on September 14th. We have gotten some feedback from them. We've gotten some questions and asks for clarification that we're currently working on. And we will be going sort of back and forth with CMS staff on that front over the course of the next few months. And we anticipate formal approval of the blueprint in early 2024, again, in time to set up the program launch July 1st, 2024. One big set of work that's ongoing right now is rulemaking for the basic health program, and so that rule drafting is underway and will be shared publicly later in 2023 in advance of the formal rules advisory committee process that is planned for early February of 2024. Again, lots of time to get feedback on that and have that public process so that the rules can take effect in advance of that July 1 implementation date. And with that, I'm going to turn it over to Katie to talk a little bit more about mitigation work.
Good morning, everybody. I'm Katie Button. I'm a plan management and policy analyst for the marketplace, and I've been working closely with the BHP team. And so we had a meeting with the carriers on Monday, and we've had several meetings with the carriers, and we spent some time Monday talking about mitigation options. So this is an overview of what we talked about with the carriers, and then I'm happy to get any questions or thoughts from you all at the end. So just to recap, we did try to find some options for federal funds. We talked about doing some 1332 waivers to try to recoup the federal funds, the silver tax. Excuse me, good Lord, let me hold on. We tried to look at some 1332 options to recapture the loss of silver load. And so the first one was that we talked about doing some sort of state administered subsidy where the carriers would reduce the premium that they bill to folks. But CMS didn't think we could pass guardrail requirements. So for 1332, just as a reminder, they're called guardrails, and there are some requirements, things like whatever you do with your waiver cannot make plans less affordable. And so they didn't believe that we could meet that guardrail if we just gave people like a $25 amount. So then we looked into doing a gold benchmark, which means that instead of using the second lowest cost silver plan to do calculation of tax credits, you would use the lowest cost gold plan. And CMS wasn't willing to update healthcare.gov to do that. So that idea, unfortunately, could not move forward. And then CMS had suggested to us that instead of doing a BHP under 1331, we could do a 1332 waiver and do a BHP lookalike, and then we could perhaps do something else with the pass-through savings on the marketplace. But the problem with that is that another of the 1332 guardrails is that you cannot increase the federal deficit. You can't cost the federal government money. And so whatever the initial enrollment is, the federal government would cover that. But if enrollment exceeded that initial enrollment, the state would be responsible for that. And we felt that it was a definite it was definitely, we would increase enrollment, and we didn't feel that the state could, he didn't think the state could pay for those extra enrollees. Next slide, please. So if we aren't looking for federal funding, we could look for other funding. And so without those 1332 requirements or other federal requirements, some of the constraints might go away. And so things that we looked at before that we didn't really like, maybe they are more workable now, or maybe there are other ideas we could explore. So we talked with the carriers about a couple of ideas. Next slide, please. So the first one is that carrier administered subsidy, and I'm going to call it the visible subsidy because we have another sort of subsidy idea, and so need them to have different names so we can keep them straight. So the visible subsidy is that the carriers would file their rate. Oh, the audio is coming in and out. Is anybody else experiencing that?
We're okay in the room.
Yeah, I'm not getting it
Okay.
either.
Oh. The joys of Teams, I think, sometimes. So with the visible subsidy, the carriers would file their rates like they normally do. And then we would work with CMS to put some sort of banner on healthcare.gov that would say, you know, your rates will be X amount lower than displayed here, check your bill. And then the carriers would decrease the bills to consumers and then submit payment requests to us, and we would reimburse them from the non-federal funds. Next slide, please. So the pros are that this helps consumers, yay! And then it also maintains adherence to rate filing requirements, so we don't have to worry about things like single risk pool or risk adjustment. Next slide, please. But there are some cons to this approach. So the first one is that it will likely cause consumer confusion because healthcare.gov will have a different amount than what the carrier is billing. And it does require a change to healthcare.gov, which can take time. And then it also requires some sort of new payment process that we don't currently have set up. And so we would have to set up that process, and we also would need staff to set up that process as well. Next slide, please. And this was not a very, carriers didn't really think this was a very doable option because it does require some pretty significant work on their part. So one of the things that would be hard for them is if we had tried to do a subsidy that maybe we gave a different amount to younger folks and older folks, or we gave a different amount to folks in this region from folks in that region. So mostly would have to do sort of one flat like amount for everybody. Then carriers have to reconcile their APTC payments with CMS, and they have to provide quite a bit of information. And so if they're billing consumers for less and getting money from somewhere else, that can be hard when they have to do their reconciliation. And then for a while, as people are moving out of the marketplace, there will be people who would be BHP eligible still in the marketplace. And those folks, some of them will have really low premiums, like $1, $3. And so it could be hard for carriers if the subsidy amount is $25, it could be hard for them to tell us which people don't need the full $25. Next slide, please. So we thought about some ways that maybe we could make this strategy a little bit better. We could do a flat dollar amount to everybody. Our initial idea when we talked about this with the carriers is that they would only provide the subsidy to folks who are receiving APTC. But if we just did it to everybody, they can just adjust everybody's bill, and they're not trying to pick and choose whose bill needs to be adjusted. We also could potentially work with CMS as a state and see if we could reduce some of the burden on that APTC reconciliation. For example, if we gave everyone $25 and CMS knew that, could they adjust their reporting and things like that so that it would be easier for the carriers to report that? And then there might be other suggestions that folks can think of as we're moving along this journey. Next slide, please. So then a sort of new-ish idea that we're thinking about is what I'm calling the invisible subsidy. And so in this idea, the carriers would reduce just the bronze and gold rates by either a percentage or a flat amount. And so, for example, they would tell us that it's $100. But we would ask them to reduce it by $25 and so file a rate of $75, knowing that they would get the $25 to make it whole. And so then, you know, they would proceed as normal with that lower rate and then submit payment requests, and then we would reimburse them. Next slide, please. So the pros of this strategy are that it's invisible to consumers because the rates displayed on healthcare.gov will match what the carriers are billing. And then if you do percentage reductions, you can more closely mimic what's being lost with the silver load. Next slide, please. The cons are that it might violate the single risk pool, which is not not something that you can do. You have to get a waiver sometimes if you want to waive the single risk pool. There are other rate filing things that can get a little funky, and the actuaries get a little nervous about that. It also would make risk adjustment inaccurate, so you'd have to do extra calculations to make risk adjustment work out. In this case where you're reducing the rate that's filed, it reduces the rate for everybody. So you would also be providing the subsidy assistance to, or excuse me, the premium assistance to off-exchange folks. So that increases the cost. It could make getting that funding path approved more difficult. And then again, as with the first strategy, we need some sort of state process to reimburse the carriers, and you need staff to do that. So that can be difficult. Next slide, please. So a couple of ideas to make this strategy more doable are that we're talking with other states who have state subsidies. They all have SBMs, so it's a little different for them, but we're talking to them to see how they administer their subsidies, to see if there's something that we can use, even though we're on healthcare.gov. And then, you know, maybe we look into a second 1332. We have one right now as a state for reinsurance. And so maybe we do something else that would help us circumvent the risk pool and the rate filing issues. And again, there might be other options. Dawn, I can't remember, do I have one more slide after this? I do, yay. So we talked about these with the carriers. The carriers were kind of interested in the second idea, and they asked more about the single risk pool issue, which I, as a non-actuary, could not really explain well. So the next steps are that we're going to set up a call with the insurance actuaries and DFR's actuaries to discuss that risk pool issue, to see if there are any ways that we could circumvent it, or if it really is, no, this is a serious issue that we can't get around. And then we have a meeting with Massachusetts next. We've talked to a couple of other states, and we'll continue to research those states that are doing their own subsidies to see if there are any other options that we can do. So if folks have any questions or ideas of things we can do, I'm all ears.
Thank you, Katie. I appreciate that. Any questions? Oh, Paul. Go ahead, Paul.
Sure, no questions, but I just thought I would share kind of what I had shared in the carrier work group. And, you know, for me, with sort of this invisible option, the reason I hope we can find a way through some of the legal regulatory challenges is that it's the one that closely, you know, can patch some of the big increases consumers would face. You know, a little bit of mitigation is probably better than no mitigation, but it would just be, hey, how can we most efficiently use these state dollars and make sure they're getting it to the people who, you know, are unintentionally suffering a little bit as we go through this transition to the basic health plan.
Thank you, Paul. So I think I'll add a couple things too, if people think of other questions, but I was on the carrier call, was it Monday, I think it was?
Monday.
Yeah, so that, and again, I just appreciate so much those calls are really well attended and organized, and I thought that was a lot of good feedback on the call. So I just want to confirm a couple things I heard, just for the sake of it as while we're talking about it. But it seems to me that whatever we do going forward, federal dollars are likely off the table. This will be state funded. So I think there were some questions about, well, how much funding would be available potentially, and how should we think about that? And I think the response, and Tim and Katie, please correct me if I heard this wrong, but I think at this point we're really just exploring options that are best, and we'll worry about funding later. So that definitely heard that. And yeah, Paul, to your point, I think the invisible subsidy did seem to be the best for the consumer, although there are some details that need to be worked out. And the meetings with the follow-up meetings with the actuaries to see how we could work through that, I think will be fruitful to investigate that as well. Trying to think if there's anything else that came of that meeting that was worthwhile. Go ahead, please, Numi.
Yeah, Numi Griffith, DCBS DFR. I mean, this discussion has really been about something that we can do with state funding. And I think where those funds come from is very much up for discussion. There is kind of a whole raft of healthcare assessments which are up for renewal during the 2025 session, which is going to be kind of a balance of discussion between DCBS and OHA about which of those subsidies are extended, how much they're extended, if the levels are adjusted, and you know, the balance of what goes to DCBS, which would probably be the entity that it is administering this program if it goes into effect, and the balance that is going to be going into OHA. You know, right now we have assessments which are funding both the Oregon Reinsurance Program, which DCBS administers, and which stabilizes rates in the individual market. And then the rest of that funding is going into funding for OHP. So that's kind of the pot of money that we're talking about potentially going in. You know, as to the sort of single risk pool issue, like I'm a lawyer, not an actuary, so I don't think I fully understand the challenges that have been raised by our folks in looking at this issue, but they've said that there's a potential problem, and so I believe them. So like that's definitely something that we want to work through. I do think that ideally, this would be something that we would want to be able to proceed with without getting an additional federal waiver. And that is because like there isn't time that getting a 1332 approved is usually a process that I would budget 18 months for. And we're trying to get this in place for the start of 2025, which doesn't give us time for that. So if there's a way to get around that, that would be better. And the other challenge, of course, is with the 1332 is you have to save the federal government money in order to get it approved, even if it's $1, though, like I probably wouldn't want to be working with that margin in terms of risk of approval. But like we would have to figure out something that is saving the feds at least $1, so we would be getting passed through in order to have that approved. And that is, you know, something that would be tricky at best to work out. So that's the perspective from DCBS at the moment. It's like we're very interested in making sure that the individual market remains healthy and working through whatever obstacles there are to making something happen that is going to mitigate the effect of the BHP on the marketplace. But there's a lot of challenges and there's a lot of work ahead still.
Thank you for that. Looks like there may be another question or comment.
Hi, Gladys Fatwell again, insurance broker. So from the broker side, a few comments, I guess it is. It's not more of a question, it's more of a comment, because if we have that flat dollar that was discussed, that makes it a little bit easier, then some people are going to benefit from it, some are not. So it's not really going to benefit the main people that I think you're thinking of trying to benefit. It might pull people off the marketplace that may not need to come off the marketplace, because if they're going to get a tax subsidy that they can then, you know, utilize on that's one thing, but then they're coming off, but they're still getting something. And now you're causing the increase for everybody else because people are off the marketplace. That doesn't seem to be the correct approach. So to help a few, you're now affecting more. And then on top of that, from the broker side, most of my clients, besides my business clients, my individuals, they're through marketplace. It's a lot easier to make updates, to have visibility, to be able to make changes. And now we're pulling off a subsidy of or a subset of those onto directly with the carrier, which makes it a lot more paperwork, a lot harder to make updates. It's giving the carriers more work. It's giving us as brokers, agents, more work, which we're trying to help more people. And when we have to spend more time doing that, that means we're spending less time helping others. Right now, between half an hour to an hour, we can take care of something. The paperwork takes us that much longer off normal hours, which means that now we're going to not have the time to be spending with more people to help them. So it's almost the way that I'm seeing it, more counterintuitive, and I'm trying to wrap my head around how this is going to help more people than not. And with all these cons that you brought up, it was like, this is not a positive thing. It's going to give me more work and all the agents that are out there more work, which is then going to affect the trickle down effect that those that need us to help them through enrolling and getting them subsidies. So that's my comment on that.
Yeah, I think that's a great comment about considering the unintended consequences potentially on the work that people have to do. But your comment about having people come off of the marketplace to access the subsidy, I'm not sure I'm following. Is that what you were suggesting? Because I'm not sure I'm following why that would happen.
Ask me that one more time, that why would they come off the marketplace?
Yes, I was trying to follow what you were saying. Did you say people would leave the marketplace because the subsidy is available?
Yeah, if they think that, hey, there's this off exchange, I have dollars that I can use, then they may decide to come off a marketplace, because even though they may have a credit on marketplace, $100, let's say, but they can get $200 off exchange, then they might say, oh, well, I want the $200 versus the one that I'm getting through the marketplace.
So if I could clarify, Gladys, so what would happen is that the whole rate itself would be less. So like if it was $100, it would be $75. And so folks off exchange would see $75, but they're not going to see the tax credit. So like if someone's on exchange and they're getting $50 in tax credit, and then we reduce that plan by another $25, they're actually getting $75 in credit, but off exchange, they're only seeing a $25 change. So, but I appreciate that you're bringing up this point of, we try always to encourage people to shop on the marketplace because of all the things that you mentioned. There's just so many more protections for folks that they can go through the exchange. So we will think closely. If we do that, strategy, we don't know if we will do it, but if we do it, we'll think closely about, ways that we can encourage people to come on exchange, and also, just being aware that people will see lower premiums off exchange. And for folks who are close on that line of getting tax credits or not, that may be an encouragement to them to move off exchange. So thanks so much for that feedback.
Motor Health is one that definitely does have certain plans that are off exchange that are less expensive. So that, and I'm sure part of the conversations that are being had with the carriers, they're known for that, and that's a good thing for those that aren't getting a tax credit and want that lower premium. So they're a good example of something like that.
Thank you. That's great feedback. Are any other comments about or questions on this topic? Well, it doesn't look like it. So we allocated a large amount of time to this because it's been a hot topic, but I think we've covered most things for the committee's interest. So we're running a little bit ahead of schedule. Katie, do you mind possibly moving into your next topic a little bit ahead of schedule?
Sure.
Okay.
Keep it rolling. Okay, so switching gears, putting my plan management hat on. So I talked to you all in July about kind of what was going to be new for 2024. And so I'm going to do a little bit of a recap on that, and then show you some updates we've made to the window shopping tool and answer any questions that you might have about what folks are going to see when open enrollment starts. So again, we do have a few changes to our plan offering. So Regents is discontinuing 3 plans. They're enrolling folks into 3 different plans that are still in the same network, so folks can keep their same doctor. And then of course, people can always choose a new plan if that works for them. And then Pacific Source is discontinuing their catastrophic plans, so we won't have any more catastrophic plans on our exchange, but the enrollment was very low in them. So most consumers are better served by a bronze plan where they can be eligible for tax credits. Next slide, please. Providence expanded their signature network statewide, which I actually neglected to tell you in July, so that might be a little bit of new information for you. So they now have, Providence has 3 networks. So in some counties, folks will have access to their Connect network, their Choice network, and their signature network. And then Motor re-entered Deschutes County and is offering their 11 affinity network plans there. Next slide, please. So here's our 2024 coverage map. You saw this in July, but now it's finalized because plans have been finalized. So Lincoln County has 4 carriers. Most of the counties have 5, and some counties have all 6. Next slide, please. So here's a list of our carriers and our plans. So we have 6 medical carriers. We certified 76 medical plans this year. Consumers will see between 26 and 65 medical plans per county. We have 6 dental carriers, and you'll see some of our carriers offer both medical and dental. And we certified 20 dental plans this year, and consumers will see between 14 and 20 plans per county. Next slide, please. So Amy COVID made this really cool coverage tier chart, which is available in the handout in a size that is actually readable. But she went through and she pulled information from the Oregon Health Plan and then our standard plans just to kind of show folks what different coverage options are here in Oregon. And then on the back, she did this understanding health coverage sheet because we know that insurance literacy is hard for folks. And so we're trying to get more information to them in an easily digestible way. And then this sheet has been translated into multiple languages and will be available on our website, and will also be available for like printed handouts at events and things like that. Next slide, please. So we have some window shopping tool updates. So our tool is scheduled to launch tomorrow, October 13th. And our vendor has done a couple things to make it easier to add and remove providers. And then I talked in July about the 3 $5 office visits that are available on primary care and behavioral health. And so they've made some updates to the tool so that information is more obvious for consumers. Next slide, please. So here's where the new functionality for provider search is. So before you would put in your information and your household information, and then you had an option to put providers or prescriptions in, and then you would move on to the plan screen. And if you forgot, you had to go back, and it was kind of hard to get to. So now when you go to the plan screen, the plans are listed down in that kind of like square. It's called a card. And so here on the card, you can see that there's a button to add doctors and prescriptions. If you have some already, you can add more, or if you had some and you want to remove them, you can remove them. So that functionality is easier for consumers who are looking for information like that. Next slide, please. And so then the $5 office visits, again, those are 3 $5 office visits. They can be used on primary care or behavioral health, and it's the first combination of any of those 3 visit types. So we have a filtering option, and the filtering is on the left side of the screen in the shopping tool. And so you can filter for plans that just contain those office visits. And then there's a little I for information. It's called a tooltip. And so if you click on that, then it will show you the language so that folks understand what is happening with those office visits. Next slide, please. And then also, again, on those plan cards, we have a new tag. So all of the plans that cover those office visits, there is a little tag right there that says 5 visits. So it's easy for folks to see that those visits are there. And I cannot remember, Dawn, do I have one more slide? Thank you. And so then I said this before, but so on healthcare.gov, the explanation text doesn't automatically display. Consumers have to click on it, but in our tool, it does automatically display. So when consumers are looking at plans and they click into the actual plan and they're looking at the benefit, they'll see. So this is the standard bronze plan. So you can see it's a $50 copay, but then it has that explanation text that says that there's a $5 copay for the first 3 in-network primary care and all these other service types. And any combination of 3 is $5. I think that's my last slide. If you folks have any questions about what is coming up for 2024, any questions that on things I haven't said or things I have said.
Great. Any questions for Katie? Well, Katie, I have one since you're here. I know the window shopping tool has been, seems like a it's been very successful, a lot of good feedback on it. Do you track the metrics in terms of how many people access it? Maybe you've mentioned in the past, but maybe you can say some things about that.
We do track it. We normally get between 30 and 40,000 users during open enrollment, but the tool is available all year long. And so usually by the end of a whole 12-month cycle, we get like close to 100,000 unique users access that tool. So people are definitely checking it out. I hear really good feedback from folks who use it. I know that our community partners like it. Even our my friends in the insurance regulator's office, they'll be like, hey, what's that tool again? I need my mom to go look at it. So we do get really good feedback on it. It seems like people like it. We don't run into too many issues and errors with it. So it's been a nice tool for us to have and an ability to show more information than what healthcare.gov shows.
Great, that's an impressive number in terms of the people accessing it.
So Katie, for those that may not have the URL memorized, can you please share the URL for everybody and who hopefully their parents that need to go look at the window shopping tool?
Yes, it's oregonhealthcare.gov/window shop or window shopping. Oh, Amy, will you put the correct URL in there? Thank you, Amy. And then also, if you just go to oregonhealthcare.gov, it's right there too. And that's actually what I do when I go access it. I literally just type in oregonhealthcare.gov. It's right there. It says shop now or something like that. It's on the the right side in a big yellow box. So oregonhealthcare.gov is really all you need to remember. And then if you go to oregonhealthcare.gov, we have all of our other helpful information like our Find Local Help tool and our employer affordability calculator.
Great, thanks. Good question. All right, anything else for Katie before we let her go? Doesn't look like it. I think next, we're still a little bit ahead of schedule, but we're going to go ahead and open it up for public comment. Right, not hearing any, we are going to head into break. So why don't we plan to be back at 10:15? Thank you, everybody. Welcome back, everybody, from the break. We're a little bit ahead of schedule, but Amy is available to talk about our next topic here, which is the 2024 open enrollment outreach and education. So with that, I'll hand it over to you, Amy.
Thank you so much. Hello again, everyone. Thank you for having me back. For those of you that I may not know as well, my name is Amy Coben. I'm the Stakeholder and Communications Analyst for the Marketplace, which means basically that I handle everything related to communications. So I want to talk about a few things here. First, I wanted to kickstart by sharing with you all some findings from our research this summer. We had 2 different research projects that we did this summer. One of them was focused on plan design with the intention of improving our window shopping tool and our plan benefits in any way that we can. And to also just understand any misconceptions that folks have or misunderstandings about health coverage. So some key things here are on the screen. And just to summarize, or I'm sorry, I forgot to tell you guys about the second research project. Let me back up really quick. The second research project was really focused on our creative assets that we've used in the past, messaging and things like that to see what is really resonating with folks here in Oregon. We did these research studies. The first one, we had a few focus groups. And then the second one we did primarily by survey. It was an online survey and phone survey, but we also had a Spanish language focus group as well. Okay, so to get into the findings, so the first thing that we heard really loud and clear in all of our research is that folks really do believe that health coverage is important. We no longer need to convince them that they need to have health coverage. They see the value in health coverage. So that was really, really helpful to know. However, more than half of the people, even though they think that health coverage is important, they do consider health coverage unaffordable. So that was definitely a key takeaway, is that we really need to emphasize affordability. One other thing that I interpreted from that is that folks really need to understand that we do have that window shopping tool available and the benefit to using that tool, and that they really need to work with an expert to help understand all the costs that go into health coverage. So the next thing is that I wanted to emphasize is that people said that they were most likely to feel helplessness and confusion rather than feeling in control and confident when shopping for coverage. And so what that really told me was that people just really don't understand health coverage to the degree that they feel they need to in order to make a good, solid, confident decision for themselves. Which I think we all kind of know. I know a lot of you do work one-on-one with clients, and something that we've heard quite frequently is that there's a lot of misconceptions with health coverage, a lot of health literacy that's lacking. So I don't think it was a super big surprise for us, but it was, I think good for us to have that research to back it up. And then the last thing that I wanted to bring up is that about half of the folks that that participated said that they delayed or did not seek care for cost reasons. What that tells me is that there's a little bit more that we should do on the health literacy side of things for folks that are enrolled in coverage. I think we all know that, 96% or so of Oregonians are enrolled in health coverage. So it's not a matter of mostly of getting people enrolled. It's a matter of making sure that they understand their benefits, what's all included. There were a lot of comments in the survey and in the focus groups of people saying that, the deductibles were too high, things like that. So it's really important that people understand what benefits are covered before they meet their deductible. And that's one of the biggest reasons why, and thank you, Katie, for giving me props, but I'm going to give props back to Katie as well for the co-creating that flyer that we did to go over the health coverage tiers. So that people can understand a little bit more about the basics of what's covered before before they reach their deductible without having to go find the summary of benefits or sorting through the all the different tools available. So those are just some of the key points that I wanted to bring up. And I just wanted to take a moment before we continue and see if anyone has any feedback, any initial reactions, anything, or any questions that I can address.
Amy, this is Craig. I do, and maybe been on the committee long enough, I seem to recall when we've done some surveys in the past, maybe the results, we would bring them back and distinguish between demographics of the group, say by age or income level or gender identity, whatever the different demographics. Did you parse these results by those, and do you have any comments about that?
Yeah, so we did definitely. First of all, the way that we broke up the focus groups for the first research project, knowing that rating areas plays a key role in access to providers and things like that. So we did break up the first round of focus groups for plan design based largely on where people live. So that was kind of the demographic breakup of the project itself. We do have a lot of different stats and things based on age and gender and things like that. What we found was that folks that were older felt more confident about which plans they were choosing and the benefits they were getting, and they were also a little bit less concerned with the cost and more concerned with the benefits that they were getting. And then of course the younger folks were more or less concerned with the benefits they were getting and really, really concerned with cost. The younger folks were also definitely more prone to feeling, it seemed like, feeling confused and maybe having lower health literacy. But I'm definitely happy to share the reports with whomever would like to see them.
Yeah, thank you for that. And I looked ahead a little bit too, and it looks like you developed some personas, so maybe that factored into how you did that.
Absolutely, yep.
Craig, if I may, I'm actually, if I can ask Shannon, Om, Nashoba, Gladys, Holly, if you agree or disagree. Well, so we have these research findings. What are your thoughts on these? Like, I like the words in bold are always stuck in my brain every single time when we do our business. Why do our consumers feel helpless? Why are they confused? Which costs are they worried about? Is it just the premiums? Is it the actual cost of care at the time of care? What have you personally experienced, or what have you heard from your clients? And what can we help, hopefully do better in the marketplace? Shannon, go ahead.
I'll kick it off. I always talk to a live body to help me kind of walk through stuff, because I do feel very intimidated and confused by all the moving pieces. Looking at trying to project out the year ahead what my health needs might be, and looking at what the dollar figures are likely to be between the actual costs in the doctor's office as well as the premium costs. It just feels very unwieldy to me. There's so many different plan types and choices and permutations and all of that. And I agree that there seems to be a bigger need for health literacy. I'm just not quite sure how we would go about doing that. But I'm not surprised by these figures. These figures really make sense to me, that people are feeling that healthcare is still, health coverage is still too expensive, and that just that overall feeling of confusion around it. Those figures really match what I've experienced as well as what I hear from other people around me in the general public.
Thank you, Shannon. I see a few folks who look like they might have gone on mute. Gone on unmuting themselves. So Gladys, are you wanting to go next?
So from the broker standpoint, I try to focus on educating my clients to understand their plans. And if they can understand their plans, then that eases a lot of the confusion. Because a lot of times they think, oh my goodness, what is this going to cost me? I get calls of this one particular example is that the dad is calling me to say, what is it going to cost? My son went into the emergency room because of X. He's at Kaiser, their insurance is Providence. It's like, okay, well, it was an emergency, and then he was admitted, and then he got transferred out of Kaiser, and he's trying to get all these different, all this care. Well, it's trying to figure out what is going on, what was through emergency, what was not, make sure that they stay in network to try to give them a better feel for, hey, this is what it's, this is your max out of pocket. However, you know, if you're out of network, then you may not have coverage, or giving them advice to where to go, how to, what to say, and then say negotiate, get on payment plans, and that way they don't feel like I cannot get care because I don't have the $8,000-9,000 of my deductible or my max out of pocket. And so that's where they get scared. It's like, that's a lot of money. Well, do you plan a surgery? Well, no. Okay. Well, then that's a catastrophic. If something happens, then that's gonna be the bill. But if you don't have a surgery, if you don't go to emergency, then it's your copay just by going to the doctor, your annual physical, there's no cost to you if it's preventive. So I try to, as a broker, try to ease their mind on that and try to educate so that when they get that explanation of benefits that's convoluted, when they already know the concept, then that makes those numbers not look so scary. And they will, you know, I will tell them, go and seek help. This is, you know, go get checked. I will encourage them, this is your cost, and make sure that they run your insurance before you be seen, so that way you know what the cost is going to be. And so it's that, going back to what was originally said, is that the education piece. And if they're educated, it's going to be easier. But the problem is, a lot of people don't know that there are brokers that will educate them on how to properly use their insurance in order to reduce their out-of-pocket costs.
Thank you, Gladys. Anybody else? Go ahead,
This is
Holly.
Holly. Hi, I'll just chime in as a community partner. I do resonate with the information on the slide. I think that even personally, I at times have those feelings come up when we're deep into the plan details, comparing plans and trying to kind of counsel people through the differences, and just interpreting all the information. And, you know, different plans present that information differently. And sometimes it's hard to even tell, what is a copay before the deductible? What is it saying here? So being a community partner that's mostly just providing choice counseling and really avoiding any kind of plan advice, you know, we really appreciate having our agent and broker partners that we can refer to when people have complex needs and really need to understand what these things are saying. So I definitely agree. I'm even kind of surprised that those numbers, those percentages aren't even a little higher, just based on my experience as a community partner. Thanks.
Thank you, Holly. Anybody else would like to share their thoughts?
I can speak briefly on that. Go ahead.
No, please go ahead, Neshoba.
Sure. I think I'd probably echo that sentiment that the others have shared. You know, this is an education-based kind of issue, I feel like, right? Who, how, and when we provide that education and those support systems, I mean, that's up for debate. But I think folks, when they enter the system and when they navigate that with themselves, a broker, a community partner, a lot of this can be alleviated. But there's so many levels of confusion amongst enrollment, plan utilization, billing. I mean, folks are hesitant to enter because they're confused, and they may have heard horror stories of things that have maybe happened to themselves or a friend or family member in the past. So it's on most of us that are engaged in that frontline work that have to try to dismantle that fear and confusion that lies within that. So.
Thank you, Nishiba. Ali?
Thank you. Just piggybacking a little bit on that comment. I think, you know, with PEB and OWEB, you know, we always talk about how healthcare is so personal in their health plans that we always, and mind you, we have a lot of advantages over what the marketplace has in, as far as tools, but we always try to take the approach of making it as personal as possible, whether that's on a web page or so they can personalize it for themselves. And I know that there's a lot of different directions you can go with that, but I think that's one thing that I think helps, because I think everybody feels overwhelmed when they're sitting down to enroll in benefits or trying to understand what plan works best for them. But that's definitely kind of an approach that we've tried to make with a connection with members. And again, I think there's a lot more challenges here, but just wanted to convey that.
Thank you very much, Ali.
Can I add something?
Yes, please go ahead.
Okay, so just resonate us.
There you go.
Okay, just resonating back on the personas and the helplessness and confusion. We're looking at a different group of people. So, you know, two things which come to my mind is a good human-centered design, which will help the person to actually navigate and choose what's best, like a choice architecture, right? Something we have, and then supported by a decision support tool. Why I want to choose this particular plan, what does the system tells? So a combination of this, and this is a totally design, which we can let the consumer decide what kind of a plan he would actually choose best for him. It has to be the system prompting him based on this human-centered design, like a choice architecture.
Do you mind saying your name and just
Yeah,
for
sorry.
the
My name is Simpson. I'm with Deloitte. I'm the Washington project manager. So yeah,
I think that helps for perspective, and I think those comments are good as we for one of our future topics here on the agenda, which is a state-based marketplace.
Okay.
Keeping that in mind too, but I think it's appropriate that to help. I think since you have that experience, knowing what we should be shooting for.
Yeah, listening to helplessness and confusion. That's the first thing which came to my mind.
Yeah, that's good. Thank you.
Yeah.
I have something to add as a consumer. This is Inez Kemper. And I don't think that the wealth of information is a problem. I think there's plenty of information available. The problem is that there's no way to compare apples to apples. You're always comparing apples to oranges. And there are so many, I have cancer, and one of the problems that I have, it's in remission. I have no idea if it's going to rear its ugly head again next year. So do I save money? Do I go, go with a silver plan? Do I go with a gold plan so I'm covered? And what is the difference really? How many, I can't anticipate what will happen to me next year. So all the information and all the plan comparison tools are useless without knowing what's going to happen. So I don't think the problem is with the tools. The problem is that there are too many plans that are way too different.
Thank you very much, Ines. Okay,
I just wanted to comment briefly on that because Ines, that's an interesting insight because I think we are trying to balance for consumers' benefits choice without confusion. And I think that's probably how we try to manage the marketplace and the number of options that were put out there. But is that kind of what you're getting at, Ines?
I mean, I think given the parameters that we have to work in, giving tools is a wonderful thing. I think the problem that is way, way deeper. I think the plans, you know, it's you can't compare. It's like, you know, it's standing like in the cereal aisle at a grocery store and being completely overwhelmed. And it's like, yes, I understand what all of them offer, but I don't understand what that means for me. And so if there was a way to, you know, rather than, oh, deductible this, you know, prescription that, just, you know, having the plans actually, you know, maybe having each provider, each insurance company provide, okay, you know, this deductible, this blah, 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 and this blah, blah, blah. And having all of them exactly the same so that you can actually, you can compare apples to apples instead of apples to oranges.
Thank you, Ness. Numi?
Yeah, just briefly, I think one thing that in Oregon, we do have standard plan options that we put out every year. That's a collaborative process between DCBS and the marketplace in terms of what those offerings are and what they look like. And that's been a policy choice that we consciously made a long time ago now, to be able to enable those sort of apples to apples comparisons, that for at least for each carrier, there's at least one option in each metal tier that, well, not gold, but at least in bronze and silver, that people can look at and say, okay, like these are the same benefits. The difference then is just network. So which, you know, that is meaningful to some people. Like certainly that's something we've wrestled about and thinking about what is a healthy insurance market, and kind of recognizing that we want a certain number of carriers in order to be able to offer choice, in order to have competition on rates, but also kind of trying to balance against the issue of overwhelming choice. And maybe we're already there because we have 5 carriers offering standard plans plus other options. You know, and one thing that we've tried to do is preserve those other options with things like patients or consumers who really want to have an HSA eligible plan, where we don't necessarily want to make the bronze option an HSA eligible, because that's not necessarily something we want to encourage people to go into if they don't know what it is. But there is a segment of consumers who have HSAs that maybe they've carried over from a previous job where that's really important to them as an option that they can shop for. So it's a careful balance. I don't know if there's any sort of reassurance that as the insurance regulator we can offer against that concern, other than we do have a set of standard plans that should be apples to apples. But maybe one of the things that you've identified with your experience is that it's not clear enough that those are plans which are uniform across all the carriers and are something where you can actually make that sort of comparison.
So thank you, Numi. Thanks, everyone. Lots of things. We really appreciate your feedback, whether or not you agree or disagree. I didn't hear any disagreement, but lots of notes. Thank you so much for the feedback. Lots of actionable items here for the team and I, and of course, also with our partners in DFR. So thank you. Amy, back to you. I think you have one final note for the research findings, and then I think we get to talk about our new marketing vendor.
Yeah, I just wanted to add one final thought just in closing on this section, is that a lot of what I hear you all talking about is something that we heard in the research, and it's that fear of the unknown. There's people who question, you know, what is it going to be if this happens? What, you know, because we don't know. No one has a crystal ball. We can't tell what's going to happen in the future, but also just knowing that there's consistency in, you know, how much are your prescriptions going to be throughout the year? You know, if I get sick, how much is it going to be to go to the doctor? That sort of thing. So I just want to echo that is something that we heard in the research. And so we are going to be working, I think, in the messaging section here, and in the supplemental handout in your packet. You'll see that we are going to try and kind of fight that fear a little bit and instill some trust by going through the marketplace. So with that being said, that was my somewhat eloquent segue into our next section. So Dawn, if you can go ahead. So as you may or may not know, we do have a new marketing firm this year. Super excited to start working with Quinn Thomas. We do have Deb on the phone or on the meeting today. Sorry, I can't find my words. And so she is actually from Quinn Thomas. So I'll let her introduce herself in just a moment. But I did just really quickly want to say we selected them for a number of reasons during a pretty competitive process, RFP process. One of the reasons why we decided to go with Quinn Thomas is because they have been working with the Washington Exchange for some time. So we knew that they would have the background knowledge on the Affordable Care Act and the exchange and health coverage in general, which is just a huge learning curve as it is. We kicked off their contract on September 1st, which caused me just a tiny bit of anxiety knowing that open enrollment is just a couple of short months away, but they've really been hitting the ground and running, and we've got some really great things in the works. So Deb, with that being said, I'm going to let you introduce yourself, speak just a little bit about Quinn Thomas, and if you don't mind talking a little bit about how Media Plus and DHM fit in as well.
Absolutely. Yes. Thanks so much, Amy. Hi, everyone. Thank you for having me here today. My name is Deb Warren. I am the Multicultural Marketing and Communications Manager with Quinn Thomas. We're a regional marketing communications agency with offices both in Portland and Seattle. I personally have over 5 years of healthcare marketing and PR experience, including supporting a nonprofit health system and the Washington Healthcare Authority. As Amy mentioned, our agency has and continues to support the annual open enrollment marketing campaign for Washington Health Benefit Exchange. So we have an intimate understanding of the industry and the landscape. We're also supported by our colleagues at Media Plus. They're an independently owned Pacific Northwest based media agency who we've partnered with over many years to manage multiple large paid media campaigns in healthcare and other sectors. They've also been involved in the Washington Health Benefit Exchange campaigns as well. And really, as part of my work with Amy and team, I'm the primary point of contact overseeing the campaign, our strategy, all of our work streams, including creative, paid media, some grantee support, events and sponsorships, and public relations. And then briefly, as Amy mentioned, DHM Research is also a close partner of Quinn Thomas. They were actually acquired by Quinn Thomas a few years ago, but we work completely independently. And so a lot of the research that was conducted in this last year to really understand folks' perspective on health insurance and any barriers they might be experiencing as they're considering health insurance. That was also led by DHM Research. So we are very familiar with the work that was done and have really utilized those findings to help inform our approach to the OE 2024 campaign. So again, thank you so much for your time today. It's really a pleasure to meet you all, and I look forward to sharing more about the work that our team is doing alongside Amy.
Thank you so much, Deb. So on the screen here, you'll see some other key players and who we're working with at both Quinn Thomas and Media Plus. We've got a really great team, and everyone is just so gung-ho and, like I said, hitting the ground running. So it's been really, really exciting to see things come together. So let's go to the next slide. So let's jump into the meat and potatoes of what you guys really want to know, which is our open enrollment campaign. So we have a primary goal for open enrollment this year of retaining the current marketplace enrollees and also, reaching the 4% of uninsured folks as well. I do want to just keep in the back of everyone's head that we are also focused highly on helping people that are coming off of OHP, finding new coverage. And we're doing that primarily through the Marketplace Transition Project, but we are keeping that in the back of our mind as we're creating messaging and creative elements for our open enrollment campaign as well. So we hope to help people get enrolled through the marketplace in 3 different ways. First, by driving awareness about the financial assistance available. Of course, we want to make sure that folks know that there is help available from local experts. So we are leaning heavily into that message as well. And we're going to increase trust with folks by making sure that we're providing personalized and targeted tactics, which we'll talk more about in a few minutes. And then we're going to really work on having some authentic multicultural marketing strategies through a variety of channels to, first of all, reach people where they already seek information or where they already go, and make sure that we are meeting them with the needs, their language, and so on, their needs to really make sure that the messages drive home. Next slide. So our campaign approach is really broken down into 3 primary kind of goals or tactics. The first is really going to be what audiences are we looking at? And so what we did, and I think Craig, you were the one who alluded to this before, we'll show you in a moment, is we created 3 individual audience personas that we think really highlights the focus of the different types of folks in Oregon that we want to reach. And that will really help inform the messaging and the creative elements that we're developing for the campaign. We're keeping those personas in mind so that we can make sure that our messages are going to resonate with those audiences. We also are focused on areas that have higher rates of uninsured folks. So Lane and Jackson counties, Roseburg and Klamath Falls cities, and Deschutes County. We know that there are pockets of uninsured folks. So we are focusing our efforts heavily in those areas, but we are going to have a statewide campaign approach. So most of our tactics will be statewide with just a little bit heavier emphasis in those areas. We are going to make sure that our messaging and our creative is simple, hopefully easy to understand, compassionate, approachable is another word that I would assimilate with our messaging. We want to make sure that we're addressing the current concerns about high cost first and foremost, because we know that that's top of mind, and really just reinforcing that if you go through the marketplace, you're going to get support with financial help, you're going to get support with finding a good plan for you. It's really going to hopefully be easier process and less daunting. And then, like I said, we are prioritizing trans creation. So we're not just translating materials, but we're actually creating them with the specific audiences in mind so that they will resonate better. And, translations are great, but they're just not, you can't go word for word and translate things. It doesn't resonate the same way. So we're just making sure that those messages are going to really stick with folks. And then, like I said, we are going to have a statewide campaign. We're focusing on awareness, consideration, and conversion. So all of our tactics are really intentionally focused on those three goals. We do have rural strategies, so we're thinking about folks in rural parts of the state and where they get information, knowing that there aren't necessarily large bus lines going all over the place and billboards and things like that. I'll never forget, I was at a meeting in Wallowa County once, and one of our partners said, unless you put it on the side of a silo, no one's going to see it. So that will always stick in my brain forever. We just, again, want to reach people where they're at and where they're getting information. Next slide, please. So this is, sorry, it's a little bit fuzzy because it's a screenshot from a screenshot, but there is a printed version in your handout. So these are the 3 personas that we've put together. And actually, Deb, I would like to hand it over to you if you don't mind, so you can describe the personas a little bit, because you guys do it so eloquently.
Absolutely, yes, thank you. And so to level set here, for our open enrollment campaign, we have a statewide approach. We want to make sure that we're in front of as many folks as possible, that there's awareness of open enrollment and tools available to help folks find the plans that fit their needs. When we're thinking about our audience personas, these are really hyper-targeted individuals that we're keeping in mind, folks that are likely uninsured, who would be most likely to seek insurance on the marketplace, or folks who may be currently insured through an employer, for example, and who may find better options that fit their needs on the marketplace as well. So while these folks are hyper-focused, we still have a very broad statewide approach as part of our strategy. So super quickly, Casey is going to be our kind of younger persona. This individual is possibly just getting off of their parents' insurance and seeking insurance on their own for the first time. This individual is typically more representative of our urban persona. They may also be, they might also have a less traditional job. They might be a freelancer, or they may have an unsteady income. And so their main concerns are really going to be cost and navigating insurance for the first time. And then we've got Mateo. This persona is a bit more rural, maybe from central or eastern Oregon. English may not be their first language. They're also likely going to be very family oriented, making decisions with their family top of mind. And so they're also likely to seek advice and also make decisions based off of those in their community and those that they really trust. And then we've got Shay, our slightly older persona. Shay is likely to influence Mateo and Casey persona. She's also our more suburban persona. They are they're really looking for, they understand the value of an insurance plan, but they're really looking for that in-person assistance. They also might be transitioning from OHP, and so really looking for help navigating an insurance plan through the marketplace. So again, just a few key callouts from each of these personas, but more details in the slide, and happy to answer any questions.
Thank you, Deb. Next slide, Dawn. So this is just a high-level overview of our messaging framework. In the supplemental materials that were included in your packet, it does break it down by persona, so you can see how we're tailoring this framework, this messaging for each individual persona to focus just slightly different on what their concerns, their thoughts, and what actions they might take. So the first messaging that we are going to be focused on is just really, let's get you covered. So we're going to be emphasizing that the marketplace is here, what we provide, and really just focusing on getting folks through the door. The second bucket is really focusing on that affordability piece. So really emphasizing the financial assistance available. Coverage is probably more affordable than you think, because we know that a lot of people are usually very surprised at how quote unquote affordable it can be. And I know affordability is relative, so we're going to try to steer clear of using the word affordable, just knowing that, people resonate with that word differently, but just making sure that people understand that you can fit coverage into your budget. And then the final piece is, again, something that we heard loud in the research is that people really want to make sure that they have coverage for their basic needs, that it's something that they're going to actually be able to use, not just sign up for. So we're going to focus on the benefits that are included, make sure that folks know that things like chiropractic and acupuncture is included. If you go to a naturopath, for example, they would be covered, that sort of thing, and making sure that folks know how to evaluate networks, prescription drug costs, and so on. So these are just some of our high-level messages that we are distilling down into the creative elements. Next slide, please. So this is just to give you an example of how our creative elements are going to look. I do really want to I do want to mention that we are adding a couple of colors to our palette. So you'll notice there's this fuchsia and this lighter teal, and that's really to expand and make sure that we are, reaching more people, capturing more eyes, and that things are really resonating well. We're also adding a new font to our repertoire. So you will notice that our ads are going to be very simple, streamlined, and really just trying to drive home the points that we're trying to hit without adding too much extra fluff in it. We're also going to make sure to add photos of people that folks that can hopefully relate to. We've got a really great suite of images that we're going to be pulling from, and I'm just really excited about our creative. I feel like it's a really good direction, and it stays in line with our current branding, but also just kind of amplifies and adds to it. So next slide, please. So I'm not going to go over this in super great detail because it's a lot of information, but this slide just kind of hits on the different channels that we'll be using and how those channels are really tied into our overall strategy. So you'll notice that we have different tactics that our goals are really going to be focused on awareness. That's going to be awareness of the marketplace, financial assistance, just the program in general. So we will have a number of different tactics that really drive that awareness. I do want to call your attention that we do have some new out-of-home strategies that we'll be using, or tactics that we'll be using this year. I'm really excited about, since Oregon's now a pump your own gas state, we're trying to do some gas pump toppers so that while people are standing there waiting for their gas tank to fill up, that they have something to look at and hopefully digest. We'll also be doing some advertisements in laundromats. We'll have some standees at grocery stores, etc. And so, you know, again, that really just focuses on reaching people where they're at. We have consideration tactics, which are very similar to tactics that we've used in the past. You want to think about display advertisements, social media, and so on. I do want to also just really quickly mention that you will notice under social channels, we do not have Twitter or X listed. That is pretty intentional. We will not be doing any paid advertisements on Twitter this year, just because of all of the political variance going on. And then our third and final, and probably our most important, is conversion. And conversion really focuses on trying to drive action and getting people to not only understand and think about the options that are available, but have them actually take action and evaluate their plan options through the window shopping tool, or even better yet, enroll. So we're going to really be focusing on paid search, retargeting, which means taking people that we know are already interested. Maybe they've already come to our website or shown interest, and making sure our advertising is following up with them to say, hey, you know, you showed interest in this. Don't forget, this is a thing that's happening. So, and we're working really closely with Quinn Thomas, even though they're new for us this year. We're working very closely with them to make sure that they know what has worked, you know, maybe what we've struggled with in the past, and make sure that we're taking that into account for the different planning of the different strategies. Next slide, please. For public relations, we do have a pretty good solid schedule set up. So starting next week, it feels like open enrollment is like tomorrow, I'll tell you guys, but starting next week, we're going to be doing a pre-OE media tour. With that, I'm going to be available for media outlets to do interviews, information sessions, whatever is really needed to get information into the hands of the press and the media ahead of time, so that hopefully we can prepare them for open enrollment and get some things going. Starting the end of October, in the first week of November, we're going to be doing what we're calling a kickoff, but it's not the traditional kickoff that we've done in the past. What we're doing is we're working with our grantees around the state to provide them as experts for the media to talk to. So if you know, there's you know, a newspaper or radio station that wants to do an interview, we're going to really try and route that to our grantees so that we can emphasize their availability, what kind of great services they offer to folks, and really position them as local experts rather than having the message come solely from the state. So that's our goal. We will do a press release Thanksgiving week. And that's really to emphasize, help your family get covered while you're sitting around waiting for dinner to be done. maybe that's a good time to talk about health coverage. I know it's always top of mind at the Thanksgiving dinner table. It honestly is in my family. It feels like every time I go to Thanksgiving dinner, someone's got health coverage questions. So I don't know about you guys. And then around the first of the year, we will be doing some last chance to enroll media pushes to make sure that we get some stories out there about the deadline, making sure that folks take action before that January 15th deadline. And I think I have one more slide. Perfect, thank you. So this is a timeline that we have put together that shows our different strategies and tactics that we'll be using and kind of when they'll start deploying and what that looks like. You'll notice that some of our strategies are going to be actually deploying before open enrollment begins. We heard a lot of feedback from you all, from partners, and just in general from our focus groups that people do like to have that lead, that leading time and knowing what's coming. So we'll be doing some of that even starting next week. We will be doing a couple of in-house tactics. So we will continue doing our newsletters once a month and then text messaging, which will not be exactly weekly, but we will have frequent text messages going out to folks, reminding them about open enrollment and encouraging them to take action. Whether that be visit our window shopping tool, finding an expert to help them, or just enrolling. I think that's the last of my slides, if I remember correctly. So I do want to take just a moment. I know we're short on time now, but I do want to take a moment to see if anyone had any thoughts or reactions. And I've got Pat open, so I'm going to take some notes too.
Thank you, Amy. And we're fine on time, so please, if anyone has questions or feedback, please offer that now.
I will say Craig looked at me and whispered, "I like it a lot." So that is going on the record. I did write that down. So thank you, Craig.
Yeah, the new colors and the style just looks great.
Thank you.
And thanks for getting us back on time too on our agenda. I think this topic seems to be a little more interesting to people than silver loading or risk mitigation, but really good information. And then it sounds like you've been able to incorporate a lot of the feedback from people, so that's good to see. I did have one brief question for you, and I think I saw it earlier. You said that you want to maintain the marketplace enrollment and then increase, or maybe it's decrease the uninsured by 4%. And I think it's good to have targets, but could you explain how you got that, or how you chose that?
Okay, so sorry, just to clarify, and thank you for bringing that up. So currently the uninsured rate, as far as we know, is hovering right around 4%. Of course, that's not taking into account yet the Medicaid renewals and people coming off of OHP. But prior to the renewals, we were sitting at about 4% of folks in Oregon being uninsured. So our goal is actually to reach those 4% of folks and encourage them to get coverage. We would love any sort of reduction of that number. I will be honest in saying that I think that our biggest goal right now is to maintain and grow enrollment through the marketplace, because I do know, I'm just constantly thinking about the Medicaid renewals, the OHP renewals that are happening right now, and the people coming off of OHP. So there is churn happening this year. So I don't know, how much we'll be able to lower that 4% number, but of course, we always have the goal of reducing the uninsured rate and making sure that folks have equitable access to coverage. So hopefully that answered your question.
Yeah, I think I just misread that. And it's, I think we're always trying to attempt to reach those people who tend to be uninsured and have options. And it's a difficult challenge, but I'm glad you continue to work on that.
And I do really quickly just want to mention that with our integration at OHA now, I've been working very, very closely with the OHP communications team. So we are making sure that messages that are going out from the OHP side have marketplace information for folks that are maybe coming off of OHP, and the other way around. We're making sure that our messaging is being sensitive to the OHP programs and making sure that people are really finding the coverage that fits them best. So it's one of the reasons why we're routing folks to the window shopping tool up until January. In January, we will switch our messaging a little bit to go directly to healthcare.gov just because of the short window to the end of open enrollment. But through then, we will be routing people mostly to our website with the intention of getting them into the window shopping tool to find the coverage that's right for them. So even though our campaign is not focused on OHP, it is obviously focused on Marketplace. We are being sensitive to the fact that we know that in that 4%, there's probably a good amount of people that would qualify for OHP, either under Healthier Oregon or just traditional OHP programs.
Looks like Numi has a comment.
Yeah, I was just kind of curious looking at the time periods here that the awareness and consideration are both ending mid-December, whereas, of course, as we just talked about, open enrollment continues in January. Is the belief that that sort of outreach is ineffective for the remainder, or is there any consideration of having additional paid advertising going throughout the period of open enrollment?
No, that's a great call out. Thank you for bringing that up. And I'm going to give you a quick answer, and then I'll let Deb weigh in if I missed anything. But what we know based on data for enrollment data for the past years historically is that people tend to take action before December 15th. Because they want their coverage to be starting on the 1st. And we also know that the auto enrollment is usually mid-December as well. And so knowing those key factors, we typically have a very small number. I think last year it was maybe around 5,000 people or less that actually enrolled between December 16th and the end of open enrollment. So we know that the majority of people are going to take action before December 15th. We also know that there's quite a bit of competition in the airwaves for the last part of the year because of holiday advertisements and things like that. And so frankly, it is very expensive for us to do placements during that time just because of the sheer competition. So we are heavily focusing our strategies on that mid-December timeline, but we will have, you'll notice that there's some white sections at the end of the awareness and consideration pieces, and that's because we will still be running them. It just won't be as heavy. Deb, did I hit all the points or did I miss anything?
Didn't miss anything. That was perfect. Thanks.
Great, thanks for the question. I think we're going to wrap this section up just so we can get on to our next topic. But thank you again, Amy and team and partners that are working on this. Looks really good. All right, we're handing it over to Chicky and Victor to talk about SBM.
Thank you very much, Craig. Good morning again, everybody. In case you have missed my name is Chicky Flowers. I'm the director of the Oregon Health Insurance Marketplace, and my pronouns are she, her, hers. Shakanya, let me just switch on my camera real quick because I am in the very, I promised way too soon. There you go. Because I am in the very back of the room over here in Salem. So state-based marketplace project, we are here. We are finally here. Senate Bill 972 passed that legislation. So we officially launched our project in July of this year. So topics we'd like to give you a quick update on are, so who is your project team? What is the state-based marketplace project? What have we accomplished so far? What is our high-level project timeline? And we would love for the committee members to participate in this exercise of reviewing the current impacted parties, interested stakeholders that we have identified and current engagement needs. And I will get to that. That's our very last slide if you want to skip ahead or hang with me as we go through slide by slide. So next slide, please. Here are our fantastic profile photos. I am the project sponsor for this project. Victor Garcia, who is with the Marketplace team, is our product owner. We have a fantastic IT project manager. She is a senior project manager with our OIS, our Office of Information Services. I need to be better about putting acronyms, so please let me know if I missed a certain acronym that you do not know what it is. So Dorosita Mardushev, I believe she's here also in the virtual room and is available for questions at a later time. We have Dan Feeder, he is our business systems analyst, and we have Talon Wood, who is our project advisor. Next slide, please. So what is the SBM project? This should be no surprise to everybody in this committee. We are transitioning away, or at least plan to, away from healthcare.gov and become our own state-based marketplace platform and call center by November 1st of 2026. So that is for open enrollment of 2027. High-level reasons for the change, of course, we would definitely love to improve the shopping and customer service experience and implement responses, be in a better place to implement responses to the feedback that we receive from the community. We would like to definitely be able to track customer issues with enrollment and resolve them in a better time frame. Next slide, please. More reasons for the change. We definitely would like to increase transparency to improve accountability to our partners and consumers. We would like to improve our service delivery to our communities of focus with real-time access to demographic data. And last but not the least, we would like the ability to customize our platform for special enrollment periods and Oregon-specific programs. Next slide, please. So we started our project right around 4th of July. We didn't wait too long. Legislative season ended and we started pretty much right away. On July 6th, on the 29th of August, we had our project charter was signed by leadership. And on September 5th, we were able to complete our business case. We have been able to obtain conditional approval to begin planning. So we are officially outside of stage gate 1. There are 4 stage gates that the state implements for large IT projects. We have passed stage gate 1, we have conditional approval, and we are very much well into stage gate 2, which is it's going to be a much longer timeline. I can't promise you we'll pass stage gate 2 in 3 months. It probably is not going to happen, but we are working very hard to move as quickly as we can. Next slide, please, which I believe will be Victor's slide.
Thank you, Chicky. So this is our, oh, gotcha. I think I might be able to advance that. Let's see if it will let me. Just one sec. We have a timeline to bring up on the screen here.
So we are having technical difficulties with our computer, so we are switching owners at this time. If you would like to reference the handout, it's slide 50.
Well, in the meantime, I can just kind of tell you where we're at right now before we advance the slide or have a chance to advance the slide. So that's without the visual, it's a little difficult to show you, but what I'm looking at is we have a project start date, as Chicky just mentioned, around 4th of July. On our timeline, we now have an orange line that marks where we're at now, and that line is after the project start date, which I cannot explain to you how surreal that is to actually have started. So we're still very early in the process, but we have begun the actual formal project planning. Chicky mentioned our project manager, Dorosita Mardashev. I can't overstate how invaluable she's been in helping us get this off the ground, get it organized for the requirements that are stage gate, which is the approval process for our state IT oversight. So the main activities we're involved in right now are we're preparing the procurement for our vendor. That'll take us through at least around spring of next year, beginning of spring, around March. And to start that, we are collecting requirements in a formal fashion now to translate essentially all of the things we've been talking about in theory and kind of get them dialed down to a detailed and captured state to actually then procure a vendor. So so right now, it's very early. We'll be engaging people that are more expert in some of the more specific areas, but the idea is to get what we're asking for kind of in that narrow band, the art and science of getting it between not being too specific so that we rule out certain possibilities, but also not being so vague that we don't get exactly what we need from an eventual procurement or a seeking of a vendor. So that'll take us from now through, let's see, probably, yeah, through beginning of spring of next year. We'll put together the procurement. The actual procurement will take place from hopefully summer of next year through the beginning of the following year. And so that'll take us into 2025. And again, once we start getting out this far, it's all estimates, but I feel at this time it'll be easy enough, or not easy enough, but possible to stick to these timelines. So the idea is that we'd have a vendor procured and execution right around the time we're also getting our 25 to 27 biennium plans, budgeting squared away, and that will also include some of our recruitment for positions that we'll need. So lots of planning, lots of preliminary work, lots of very early groundwork being laid now that'll get more specific as time goes on. This time will all pass very quickly. So you can definitely expect to see more of these updates as we go forward. And we can also keep the committee in the loop on a monthly basis. So it won't just necessarily be at every meeting that we have every few months, but we'll be sending out monthly updates as well to let you know where we're at. I think we're almost back. Okay, we're going PDF.
All this is me trying to help out and troubleshoot. So you are seeing the slide deck, the handouts. It's a PDF. It's not the best resolution, but kind of to show you where we're at in terms of the handout that you have in your Outlook calendars.
So there's a lot of months on there. The timeline for this, I think it says 4 years, it might be actually 3 years, 8 months, but to implement something like this does take a long time. The longest amount of time is, or a good chunk of the time is the actual just planning for everything. Once we have a vendor on board, our plan is to have a vendor on board around summer of 2025 or just before, in order to have enough time to get everything ready for November of 2026 for that open enrollment. Vendors, at least from what we've seen from other states, need at least a year to get everything together. And that's at the absolute minimum. So we're hoping to stretch that out to something more like 18 to 20 months to give us plenty of time to make sure everything is ready. And that we can do all the appropriate testing and everything that's needed. So again, very early days. We are on track with the few milestones we've had up to this point. And we have definitely a lot of work to go just between now and springtime to make sure we get everything ready. So that's just a quick overview. Any questions about the timeline or how much time this will take? None. I guess next page.
Oh, looks like there is a question from Paul.
Oh, yes.
And it may be just a broader question or curiosity, but at this point, as you said, it's early. Is there anything that keeps you up at night more than something else? Any particular checkpoint you're maybe slightly more worried about as we move forward? Just given how long this may take.
Yeah, pretty much everything from the orange line to the end. But, I'd say this beginning part is the kind of work that I'm least familiar with, because what I've done so far is put together amalgamations of a lot of information from other states, evaluations, analyses, and this is the actual rubber meets the road collection of requirements, which I don't have hands-on experience with. We have some folks on the project team, Dan Faders, with Office of Information Services, and he's helping us to get that started. So once I have a better handle on how that works, just knowing how important that is to get those dialed in correctly, to then get what we need from a vendor, it's the foundation on which we build that request for vendors to propose, but then it's also sort of an obligation to stick to what we've said when we do those contract negotiations. So getting that right is very important. So right at the moment, that's the most immediate thing, but it's also kind of the thing that I guess you could say keeps me up at night is making sure we get that part right. After that, there will be, a lot more hands involved, a lot more folks come on to kind of help with the more specific parts of the implementation. But just making sure we have that foundation done properly will be very important to making sure everything goes well after that. Any other entities that that we may need to during implementation, and that's also any interested parties that have I guess a vested interest in how specifically the platform turns out. So we're talking about agents, community partners, tribal organizations, tribal governments, folks that will have a vested interest and a voice in how this comes out in the end. So we'll be looking for those and communicating with anyone who might want to participate in some of these conversations. And then the key considerations that will be addressed during the transition. And that will be kind of, again, what I mentioned, some things that will impact those parties directly. And then also any roadblocks that we may run into, any barriers to any goals that we have, any issues that come up with things that are unexpected. So, for example, any issues that may come up from the basic health program implementation, collaboration we may need to do in order to implement our solution properly so that it meshes well with that solution, and some of the limitations there given our timeline. So these are all things that we will continue to discuss with the committee, continue to discuss with anybody that's affected, and ultimately, what these bullet points are all getting to is that transparency will be key. We'll be finding a number of ways to hit that transparency. So we'll have a project website set up. We'll also have a part of our requirements as an independent quality management services vendor. So this is a third party that we have to seek and hire from a state contract. And that's essentially, they are experts in project management that keep an eye on our project to make sure that we're doing the things you need to do to get an IT project executed properly. So extra eyes on, they will then provide reports to make sure we're on track. And again, constant communication with legislators, oversight entities, all those things will all be captured in these messaging things going forward.
So Victor, I'll take the last slide. Once I figure out how to center this correctly, maybe, hold on. Okay, so just to remind folks, if you go back to the timeline, the pre-implementation phase is really now through March of 2025. So this will cover the request for procurements, the vendor selection, and this is before we really get going with vendor implementation. So what you have in front of you is a high-level grid of our interested parties or our stakeholders. And we'd love for your help to really make sure that we hopefully have the baseline version of our stakeholder plan, if you will. So are there any missing parties? How often should we engage? And what method should we use? So it's very small on the screen. I'm hoping you can look at your handouts for a better view of it. So weekly, we will be holding meetings, emails, and of course, chat as needed with the Office of Information Services. The one team is the Oregon Eligibility System team. That is a team that handles, of course, the OHP side of health insurance over here in Oregon. And of course, Oregon Health Insurance Marketplace staff and team. we will be engaging, we meaning the project team, the core project team will be engaging with these folks on a weekly basis. On a monthly basis, via meetings, emails, and we'll also have a web page, hopefully by the end of this month or early part of November. We will be working with the Department of Administrative Services, Enterprise Information Services. So that is pretty much the IT. This might be an oversimplification because they do so much more, but they are the IT team that handles all of the state. Health Insurance Marketplace Advisory Committee, the Oregon Health Policy Board, the Governor's Office, OHA Leadership, CMS or Centers for Medicare and Medicaid Services, Center for Consumer Information and Insurance Oversight Team, and of course the Division of Financial Regulation. So this list is our group of stakeholders for a monthly cadence of communication during the pre-implementation phase. And on a quarterly basis, we will have partner agents, community partners, marketplace insurance carriers, tribal groups, marketplace enrollees, legislators, media, and the public. I'd like to call out, it is very, very small on your screen, but in the handout there is an asterisk. We will be holding requirement sessions. We will schedule those as needed with our partner agents, community partners, carriers, and our tribal groups, because of course these are some of our closest and more highly impacted group of stakeholders. So HIMAC committee members, are there any missing parties? How often should we engage? What method should we use? Are we missing anything in this baseline version of our stakeholder engagement plan? And if you say it's perfect, I will also take that.
Chicky, just so I'm clear, this is the engagement plan between now and
March of 2025.
Oh, okay.
Yes, because just as a reminder, we will not be going live until November 1st of 2026. So after this, there'll be a different engagement plan because we will be in an implementation phase and going live, getting ready for go live.
I apologize. I can't. I think I can read it now.
So the committee will be, of course, in a monthly cadence via, ideally, probably via email. And of course, we also will have a standing agenda item at our committee meetings.
So I'll just comment, maybe others things to add. So I think that this makes sense over that time frame. I am curious between now and procurement, if there's going to be more input or opportunity to, I'm kind of curious about how that's going to come together.
So there will be, so I mentioned there's an asterisk, like if you look at the right side of the slide, there are asterisks beside the agents, community partners, carriers, tribal groups. We will hold requirement sessions. So we will need to build in their input into our request for proposals. This solution is not just for us, right? It's for everybody. So we will need to make sure we hear your feedback and try to incorporate as much as possible into the requirements of what we're going to ask for vendors to hopefully provide their solutions for.
Okay, that's helpful. And do you mind, Dawn, can we roll back up to the timeline or whoever's? Yeah, I've got it. Okay, so I guess what I'm curious, when do we select a vendor?
So it's inside of that solution vendor procurement. That's the blue bar on the bottom. So during that period, that's us preparing the request for proposals, sending it out, getting responses, and then choosing a vendor and executing a contract. That's all in that kind of blue bar that goes through spring of 2025.
Okay. So
the actual part where we would like send out the request for proposals would be summer of 24. I don't think that's necessarily marked specifically. It's inside of the solution.
Okay, I'm a whole year. Okay, thank you. Looks like there's a comment.
I see a hand raised. I just can't see who it is because of the.
It's Dorosita. It is our project manager. Dorosita, please go ahead.
So according to this timeline, our plan is to be able to post an RFP by April of 2024, and then we'll go through the evaluation process and select a vendor. The goal is to select the vendor by, we're planning 4 months of that activity. So by August of 2024, selecting a vendor, and then we'll go into negotiations.
Thank you, Dorcita. Sorry, I had not unmuted in time for your response.
Good. Any other questions or comments on this section? Sounds like this will be a regular topic.
It definitely will. We know how invested the committee is with this project, so we will definitely keep you in the loop as often as we can. Excuse me.
All right. So next topic on our agenda is an update from Nina Rempel, who will talk about the Marketplace Transition Project.
Thank you. Good morning, everybody. This is Nina Rempel. I use pronouns she, her, hers. I'm the Marketplace Transition Project Manager. And so we'll go to the next slide. So here we're again just showing you the PH Tech call center hours. They're our Transition Help Center. And as of I'm sorry, CMS has reported back to us over 9,600 folks that have not yet enrolled in Marketplace plans since the beginning of the redetermination process. We're also now receiving Oregon Health Plan request for information, RFI, non-renewal or renewal non-response files. The September file had approximately 31,000 records in it. The October file had about 34,000 records in it. A lot of this information is shared on our dashboard. Next slide. So the new work, which is the OHP RFI non-response files, these are procedural closures. So basically, because they did not respond to the request for information, their eligibility determination was incomplete. So these procedural closures are not referred to healthcare.gov. So they would not be getting the letters that we have been sending out to members that have been reported back to us with those plan choices. We are, however, as we are with our CMS weekly files, sending out text messages and emails to these OHP members. As a result of the approximately 17,000 members in September, trying to make 3 attempts to reach the member could result in over 50,000 calls. We're actually seeing an increase in calls coming into the call center, as well as emails coming to the transition box asking for more information. So this this body of work has actually been a good avenue, a good pathway to reach more Oregonians. Next slide. In July, there were some OHP members that received erroneous system-generated notices. So instead of getting closure notices advising that they would be getting, that they have 60 days to when their benefits would end, they actually got continuous enrollment notices telling them that they had 2 more years. Again, this was incorrect. This was because of an implementation for the continuous enrollment program. And so those folks got notices in September that they had 30 days to respond to their RFI. And in October, we will be getting the file of the folks that actually were found ineligible for OHP, as well as for additional RFI work. So this is on top of what we are normally seeing in October. So that extra work is coming our way, and we've already given our partners over at PH Tech the heads up that they'll have this additional work. Next slide. So this is the project so far on our dashboard as of October 3rd. You can see that we've referred potentially 48,700 people, getting letters of 43,000 people. And so there's quite a bit of work going on over here now. Next slide. So our call center activity. So as of October 3rd, we received 1,448 calls into the call center. And actually, because of this new RFI work, yesterday we received 124 calls into the call center. So this RFI work has dramatically increased the work that we're seeing, which is great. We've made over 50,000 calls, outreach calls, since the project began, and that would be to the return mail, that would be to the RFI folks, as well as the weekly members that we're getting back from CMS that have not yet enrolled into plans. Next slide. So I'm trying to illustrate for you what the enrollment, how the enrollment this year compares to last year. So we just tried to take the chunk of time between July and October. Last year, we had an enrollment of 128,000, but that was a drop of 2,400 since the beginning of open enrollment. And this year, we are seeing an increase of, while it shows 399, the total of because of the total enrollment of 127, 234, it's actually more than that given the attrition from the beginning of open enrollment to where we're at. So we've actually seen a little bit higher than that, but this is just kind of an illustration of that. Next slide. So this is the list of grantees that we have for this project. They reach various communities of focus that we're trying to reach. The one at the bottom, Casa Latinos Unitas, coming soon. They are based in Lynn and Benton counties and also reach into Lincoln County. So we don't have any partners in that area. So we're very excited to work with them and make progress in that area. So overall, we have granted $875,000 awards to these community partners to try to help these communities, Slavic, Black, and diaspora, Latino, Asian communities to find more help available to them. Next slide. So this is, again, just a reminder of how to help people losing OHP benefits. If someone were to ask, we're, like to remind them that there could be financial assistance programs through not-for-profit hospitals and affiliated clinics, as well as to educate through their options through the marketplace window shopping tool, as we've covered quite a bit in this meeting today. Next slide. And again, how to help. We like to make sure that people understand how they can find help on the locator tool with assisters and insurance agents. Any questions for me?
Thank you, Nina. Any questions? Yes, I'm sorry. Go ahead.
Yeah. Thank you for this overview. This is very interesting. I just want to kind of clarify some of the stuff that fits into those numbers, that in terms of the sort of between 40 and 50,000, that's not 40,000 people who are now uninsured. That's 40,000 people who are potentially eligible for marketplace coverage. So some of those people may have employer-sponsored coverage now. Some of those people may have moved out of state, and that's the reason why the marketplace, why OHA was unable to reach them previously. And if somebody was, say, Medicare eligible, had become Medicare eligible, they would be in that not eligible for a marketplace coverage category. Is that more or less correct?
Yes, and when we're looking at the numbers of the 55,000 that are being referred to us, we then go through and filter out people, you're correct, people that are no longer in the state, people that are eligible for Medicare. And so that's why the difference in number of people that are referred to us and the number of letters that we're sending out, because you're right, we're not trying to reach people that don't need marketplace coverage because they have other coverage available to them. One of the things we are seeing when we are making the outbound calls to people that have not yet responded to their OHP notice or to the marketplace for enrollment, we are trying to gather the information. Do you have employer coverage? Do you have, other coverage through another source? And so that's been interesting. That's been good to find out.
Very helpful. Thank you.
Thank you.
Any other questions for Nina? Well, thank you for that update. Very important work as people are navigating this transition. So thank you for that, and look forward to future updates.
Thank you.
Yeah. All right, so now we're at the next opportunity for public comment. So I'll see if anybody has public comment. Okay, doesn't sound like it. So 2 more pieces of business for the committee before we get to the end here. So in your packet, you should have received our 2024 baseline work plan. And just to familiarize everybody with that, each year we develop a work plan. And those items are what's highlighted on the agenda with the asterisks that I mentioned at the beginning of these meetings. So we have the 2024 work plan that's been updated, and hopefully people have had a chance to review that. Are there any comments about the work plan before we approve that? Okay, not hearing any. I will ask for a motion to approve the 2024 work plan.
Ron Gallinat, so moved.
Thank you, Ron. Can I have a second?
Holly Sorensen, I second.
Thank you, Holly. So either say aye or put in the chat aye for approval. Everyone in favor, say aye.
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 Okay, I think that's been approved.
Thank you, everybody.
Thanks. And then the last piece of business. So we do have a charter and bylaws for the committee, and those needed to be updated as required by Senate Bill 966. So hopefully people have had a chance to look at that. The items that have been changed were highlighted in yellow. A lot of those, I don't think I would say it's materially changed, just changed to keep in sync with the laws that have been updated. Items such as having an ex officio member from the OHA as an example. So any questions or comments on the charter and bylaws before we move to motion? Okay, not hearing any. I'll ask for someone to approve the update.
Ron Gallinat, I'll move approval of the updates to the charter/bylaws.
All right, I think that's a trifecta for you, Ron, on the motion to approve, so thank you. Anyone to second?
Ines Kemper, second.
Thank you, Ines. And again, either say aye or put in the chat approval. So all in favor to approve, say aye.
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 Okay, I think that passed as well. All right, so that brings us to the end of our official agenda. And in closing, I thought I would just turn it over to Chicky you had any final comments for the group?
I do have final comments for the group. In case you've missed it, it is 19 days before open enrollment. Open enrollment for us is November 1st of this year through January 15th. But I'd really like to take a moment to really highlight and highlight for everybody that this is such a group effort. So if you hearken back to Katie's presentation, there's so much work to get ready for open enrollment from everybody, from our carriers to our community partners, our agents, and of course, not to count DFR, Division of Financial Regulation, and your marketplace team. So for the upcoming year, we have 6 medical carriers, 76 medical plans, 6 dental carriers, 20 dental plans. That's a year's worth of work from our fantastic carriers who year in, year out, they do what they can to offer quality plans for Oregonians, and our partners over at Division of Financial Regulation, making sure that we can make it as affordable as possible. Katie Button does, on top of everything else that she's being assigned to do, is also certifying plans. So calling out our carriers, they have been fantastic partners through every year. We are entering our 9th open enrollment season on healthcare.gov. We've had more open enrollment seasons before that, but we are here because we have fantastic partners. And then the last thing that I do want to note, our community partners and agents, I know you've been so busy getting ready. You're entering the fastest marathon every year. Please stay healthy, because we know this is a very, very busy time of the year, plus not counting it's the winter season. So Holly, Ron, Nashoba, who else am I missing? I'm sure I'm missing a lot of other folks. We know this is your busiest time of the year. Thank you so much for all your time and effort for educating people about health insurance and making sure they sign up for the best plan that meets their needs and for their family needs. So it's not every year we do this, but there's so much work that happens in the background that I just want to make sure we publicly recognize that it is so much work and it is such a collaborative effort from everybody to make this happen for every open enrollment season. So here we go, 2024 open enrollment season. Thank you so much, everybody.
Great, well said, and thank you for your leadership at the marketplace.
Thank you.
All right, with that, unless there's any other comments, I think we will come to a close. So thank you, everybody. Closing the meeting.
Thanks.
Thank you.